Good afternoon, everybody, and welcome. My name is Fungai Morao, and together with my colleague Longred Kwayem, we would like to welcome you to this live broadcast. This is part two on race, ethnicity, and health outcomes webinar. This webinar is being recorded, so if you're unable to join us for the full duration or would like to recommend us to your peers and colleagues and friends, it will be available online along with part one on the SWIFT website. We would like to thank all our incredible speakers for honoring our invitation and accepting to be recorded for this session. The format of this webinar is broken down into three parts, as you can see on the agenda. The first is a panel discussion reflecting on research priorities relevant to Black, Asian, and minority ethnic women living with HIV, followed by a second part, which is a set of two presentations, the first on safer sex and PrEP among Black and minority ethnic women in London and Glasgow, and the second on how HIV research can be informed by using stakeholder engagement and co-production to enhance research design and dissemination. After the presentations, we will take a very short 5-minute break to allow you to join your designated Zoom rooms, where we will have discussions on potential research questions pertinent to BAME women living with HIV. We will conclude the webinar by coming back together from our rooms. I'll now hand over to Longred, who will introduce our panel.
Thank you, Fungai. Our first community panelist, who will be sharing her reflection on research priorities relevant to Black, Asian, and minority ethnic women living with HIV, is Bakita Kasanda. She's a highly experienced peer researcher. She's a health activist, writer, independent consultant, and poet with a wealth of experience, both on national and global fronts. She holds multiple roles and is a strong advocate for meaningful involvement and community leadership. Thank you, Bakita. Over to you.
Very much. Hello, everyone, and thank you so much for the invitation. It's a pleasure to be here. So I wanted to start this presentation with a quote from Lilla Watson to really focus on the importance of co-working and agency and respect of community knowledge. If you have come here to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together. So a little bit about me. So I'm a researcher incorporating co-creative approaches, and I've worked on a range of different research projects. I have been a research participant in a range of studies as well. And as Longret said, I'm a writer and advocate within the HIV field. And I'm a Black woman living with HIV, and that's going to really inform a lot of what I speak about today. I'm going to bring in some elements of the work that I do, but really focus on the priorities that I see relevant to me as a Black woman, as well as my peers as well. Now, I wanted to kind of link back very quickly to the first symposium, which I really valued and I learned a lot. And one of the things that the speakers spoke about was the terms that we use and how we use those terms. So for the interests of this presentation, I'm actually going to use the term racialized women, unless I'm referring to a piece of work where they've specifically said women of colour or BAME. But I want to recognise the importance, as was highlighted in the first symposium, of being specific where we can be when we're talking about specific groups. I think generally it is important, and especially within the HIV field and the HIV research, to ensure that there's particularly not the erasure of people of Asian, South Asian descent and Latinx people as well. So one of the roles that I have, I'm a peer researcher and I work at Terence Higgins Trust on a project called Intuit. And this is a project that's led by Newcastle University in collaboration with different academic and non-academic partners. And it involves a series of different studies looking at self-management of HIV in relation to digital health. Now, digital health and the implementations of tools have been and will continue to be used in terms of managing long-term conditions as well as HIV. And it's particularly important that as they are being used by healthcare professionals, people with lived experience as well, that our voices are included in that research. So it has been very important to me as a peer research to ensure that women are included, and especially racialized women as well, as we are disproportionately impacted by HIV. And ultimately, a peer researcher is somebody who shares the same lived experience as the participants who are being involved in the whatever research project happens to be going on. So as a research participant myself, and as somebody who has been involved in taking part in studies before I would have considered myself or called myself a researcher, here are some of the things that are always at the back of my mind when I'm being invited to take part in research. Are the research questions relevant to me? Have I been centred or even considered, which is sometimes clear to see in pre-interview questionnaires or the way in which questions are even worded? Is this research looking at something that I may or we may already know? Is it adding and building to knowledge and thinking about solutions, or is it reaffirming inequalities that have been evidenced for quite a long time? And how am I and my peers being involved? So is there a co-production element to this, or are research participants only being involved after the design and the building of the questions? So for the interest of time, I won't go through all of these, but potentially pick up on a few. But the priorities that I see for racialized women living with HIV, are research gaps, treatment, aging and understanding aging, the impacts of comorbidities, mental and emotional health, advocacy, and focusing on quality of life. So in regards to treatment, and especially in regards to long-term use, one of the things that I feel a lot of us are worried about in the back of our minds is the impacts in the short term and also in the long term of the use of ARVs. There's recent studies that are showing in terms of like how Black people and women are disproportionately impacted in terms of like weight gain when it comes to integrase inhibitors. But what does that mean if you are Black and if you are also a woman? Some of the priorities are, it's really important to think about how information is being disaggregated and how it is relevant to people in a more intersectional lens and through a more intersectional lens. When it comes to research gaps, for example, I learned a lot from the PRIME study, which had a good representation of racialized women, BAME women, and it helped me to think about what life might be for me when I'm aging and things to prepare myself for, and things to anticipate to feel better equipped for when hopefully the time comes when I'm of menopausal age. And as we're thinking about getting older, I just wanted to mention the We Are Still Here campaign that's being led by Sophia Forum, and it really it's highlighting some key asks around aging and the experiences of people who are long-term diagnosed. And as somebody who works with young people who are living with HIV, I think one of the things that I want to really draw out as well is the importance of remembering different cohorts who are also long-term diagnosed. as well as people who are older, but also young people who are in their 20s and 30s, born with HIV, acquired HIV through childhood. What is the impact of treatment when you might have started taking your medication in childhood or in adolescence? And I think an important priority area as well is linked to advocacy and focusing on quality of life. Yes, within the healthcare setting, yes, in regards to having the best treatment and services available to us, but also thinking beyond that setting as well. We know that women living with HIV are more likely to experience poverty. We know racialized groups are more likely to experience poverty. So thinking about advocating for improvement of laws, and the improvement of policies, for example, how insurance is available to women living with HIV and racialized communities living with HIV as well. And I wanted to touch on this quite quickly, but I felt it was important for those of us who are working within the HIV field to also consider what other groups are doing who are focusing on the needs and the experiences and the asks of racialized women, racialized people, people of colour, who are maybe not living with HIV, but the links are still there. So at the top, we've got Decolonising Contraception, who is a collective focusing on the reproductive rights of Black people and people of colour. And at the bottom, there's references to Black Ballad and a campaign that they have done about the experiences of Black women in motherhood. And it links back to what I was saying about research, and is it about research that we already know? Now, many of us will be familiar with the statistics about Asian women being 3 times more likely to experience complications and mortality during birth and after birth and during pregnancy, 5 times more likely for Black women. This is a statistic that we're constantly presented with, but there's less of a why and what can be done. Black Ballad looked at the experiences of Black women and actually asked Black women, what are your experiences being a mother in antenatal clinics, trying to conceive, and built a better picture of why that 5 times more likely might be happening based on the experiences that were articulated in that research. So finally, I want to mention this as a peer researcher because I work within Intuit and other projects. I do work within a co-production and a co-created model, but I won't touch on this too much because I know that there is a session dedicated to this. But I really want to just stress the importance that when we're thinking about the research priorities of racialized women living with HIV, we need to think about how we're bringing our expertise and skills together, how the lived experience and our voices are not just involved as research participants, but also involve the scope, the design, the data collection, the dissemination of the research findings, going back to the quote that I initially started with, Lilla Watson, about coming together for liberation. So to close, I think research priorities amongst my peers and within my community, it's really important that we have disaggregated data so that we're better able to understand how findings impact us, how gaps in knowledge can help us live more fulfilling lives and more informed lives, the importance of lived experience being integrated in every aspect of research, and then also the flexibility to work with different people of different experiences. And going back to the questions that I always reflect on when being asked to take part in research, it's important that this research ensures that racialized women are not disenfranchised and that the projects and the studies are created in a way that we can feel centered and seen. Thank you very much.
For that really stimulating presentation. It's really interesting to hear your perspective, and I think it's really important. You've brought up a lot of really sort of broad and intersectional issues centered around quality of life. And I think that quality of life, like you say, is only possible if there's meaningful involvement around the people who are centered. And also, what does meaningful involvement mean? Which is why it's important as well to make sure that we don't leave anyone behind. Like you're saying, there are different cohorts of people, and it's about reflecting to ensure that when we say we are doing meaningful involvement, what does that mean? And are we advocating for those who cannot advocate for themselves? But that also means that we have to be working together to also, in a respectful sort of partnership, to ensure that we are actually addressing the issues that are important to these people who is us, really. So actually, we important that we are sort of in the lead for these issues. And I think it's really important as well, the point you made about use of terms. And I think it's important you mentioned that, because it's almost like the first step to identify the differences that we have in the term BME, and ensuring that then we're able to see what the needs are for people. So thank you so much for that. And I hope that people will be able to find a lot of the content there to then have these discussions that we intend to have in a short while. So thank you very much, Wakita. I will then hand over to Hosanna, who is our next panelist, and she will also be sharing her reflections. She is a woman living with HIV with over 20 years of experience working with communities. She's an African community leader, founder and former CEO of WAPENU, a peer-led cultural sensitive organization for Africans. Thank you, Hosanna. Over to you.
Thank you. Thank you, Longret. I didn't do a presentation, but I'm just going to be speaking as a person who has been long involved on the ground with people living with HIV. In the UK, there are more African women affected by HIV compared to any other group of women. The main reason is most of us are coming from countries where health systems are not robust enough to deal with pandemics. Another issue is that young African women are given a different perspective as they grow up. With two others, I founded WAPENU Health and Wellbeing Project in Glasgow, a peer-led organization working with Africans in a culturally sensitive way, because I had come to realize that there's no better way to engage with people if they realize they are dealing with someone who understands them culturally and is also living with their condition. The organization has been running now for 7 years, but securing funding has always been a problem. This is a recurring theme of peer-led organizations, especially if they involve Africans. You are generally given a shoestring budget to run, and then there is a tendency for the funder to want to micromanage, which suggests a lack of trust. When an organization has a small budget, how then does it come up with quality literature to give to their clients, informing them about the various tools that can protect them from acquiring HIV, such as PrEP or PEP, etc.? I've yet to see a leaflet here in Scotland that is written in Shona, Swahili, Yoruba, or in fact any African language in any of the HIV clinics that I have visited. If one has no or limited English, then it becomes very difficult to communicate. I also believe there's a lot of willingness among Africans about the whole HIV research field. We read about research being done and the results are published for our earnest contemplation. But then what? To what end do we benefit? In fact, who exactly benefits from all this research? The term BAME is also very, very confusing. It lumps people with very different experiences and expectations into one pot. Speaking from personal experience, I'm not expected to relate to someone from Afghanistan or Pakistan because we have different socialization and values, and even our cultures are very different. But when they are looking at our health, they will say Bame. It really does, to me, it doesn't make sense because my experiences will be very, very different. Being migrant woman, of which I am, comes with its own problems surrounding immigration, marginalization, and poverty. Even with having the right to stay in the UK, you then struggle to find a suitable job commensurating with your qualifications. Out with much needed professions like medicine and nursing, it is very difficult to find the right employment. African women end up being underemployed or doing menial jobs that keep them in poverty. And it is often a joke in the Zimbabwean community anyway, but it's sadly true, where we say people with degrees or PhDs or diplomas are doing BBC, which means British bum cleaning. But that's exactly what most of us will end up doing. We have a lot of mental health issues, and those are never addressed in our communities. We never get to a place where we sit down and talk about the issues. And it can be difficult because most of us are lone parents, where you can't talk to your child about your problems, your day-to-day issues. So at Hupenyu, we decided to come up with talking therapies for our clients. And most of those issues that Pakita has already spoken about, which is about marginalization, poverty, being racialized, we are being raised all the time. And people tend to forget that as Africans coming to the UK, we are coming here to develop a better life for us and our children or family back home. So we live what I call double lives, one in the United Kingdom and one in Africa, where you are sending money to Africa all the time and living here in poverty, and you are not making a lot of money. So these are some of the issues that need to be addressed. And it becomes hard as an African woman, or because we suffer a lot of isolation. We are fraught with many issues such as stigma, discrimination, real or perceived, poverty, not being able to provide for children, being lone parents with no social networks, leading to harmful isolation. The COVID pandemic has just exacerbated this situation for most of the African women, and that in itself, we don't even know how to deal with it. And I think I'll just say, I think all the research is out there. Um, we have had so many research papers done, but I have not really seen the implementation or the money being put towards the women of color. So that is my major issue. Thank you very much.
Thank you very much, Hosanna, for a very thought-provoking reflection. I mean, we all live through these things, so they're not news for some of us. And it sounds like a lot of the issues are quite intersectional. I would like to ask you just one question before we move on to the next presentations. I know that you've been working within the community for a very long time. What do you think is the role of community-based organizations? And do you think that they're getting the right support to be able to support other members of the community? Because that's what you've been doing for the last number of years.
They are not. I mean, this is what I'm saying. We struggle to get funding. Small black-led, peer-led organizations are struggling to get funding. And should you get the funding, it's minuscule. It doesn't allow you to develop and to come up with many projects. So it's hard. The funding is very hard. You get situations where what I call band-aid solutions, where you have a big organization comes up and says, oh, we have an African project running here. And they put one or two Black people and they say, this is your project, but we are doing it for you. Why are you not coming to this project? You don't understand me. You do not know me. Just because you have put two Africans there, it doesn't mean you have solved my problems, because your issues have got nothing to do with what I am going through as an African woman in the United Kingdom. So this is the problem I have found. It's very difficult. And we cannot sustain Black-run organizations as long as we do not get the monies and the finances. That will keep us very marginalized as organizations, as people, and in everything else.
Yeah. Well, thank you for that. I think between the two of you, you've given us a lot of food for thought. And I'm really hoping that the people who are on the webinar will be able to, obviously, these are your experiences. And I'm sure that a lot of people share that, but also people have other experiences as well. So I hope that we'll be able to merge them and have robust discussions in the Zoom sessions that we'll have later. Thank you so much to both of you for sharing your reflections. I'm going to move on now to the presentations, and I'm going to start with our first speaker, who is Sarah Nakasone, who is an anthropologist with a wealth of experience working in the US, the UK, and South Africa, researching and advising on equity in sexual health outreach programs for adolescents and young women. Sarah will be making a presentation on safer sex and PrEP among Black and minority ethnic women in London and Glasgow. Thank you so much, Sarah, for coming. It's over to you.
Thank you. All right. First of all, thank you, Bakita and Hosanna, for really incredible reflections and presentations. I was lucky enough to speak with Hosanna before I started this research, and it helped shape so much of what we did, both in recruiting, interviewing, and then analysis. I'm going to take the next couple of minutes to speak about a research project I helped run in the summer of 2018, and that research project was the Women to Women Project. And the goal of the Women to Women Project was to discuss barriers and facilitators among PrEP candidacy perceptions in Black and minority ethnic women, specifically in London and Glasgow, since that was where we were doing our fieldwork. We knew that there was this drug that could prevent HIV. In Scotland, it had been rolled out through the NHS at that time. In England, they were just getting ready to roll it out through the IMPACT trial, but we weren't seeing very many women take it. And we wanted to know, was it just a matter of women didn't know that the drug was out there? Or were there differences in how people thought about safer sex, in how advertisements could be used to appeal to people, in how, community members and people around them were talking about HIV prevention, and how they themselves thought about their own safer sex lives that was potentially blocking access to PrEP, or on the flip side, might facilitate that access to PrEP if they knew the drug was out there. That is obviously a huge question. I think it's a question that we are still struggling to answer, at least at a policy level. So we broke that question down into more sub-themes for investigation. So first, we wanted to know, how did the women in our study think about safer sex? It's one thing to go into a sexual health center and for them to say, well, safer sex involves testing and safer sex involves condoms. It's quite another to think about what is going to make you feel safe during sex when you are with your partner, when you are entering the bedroom, when you are navigating what a long-term relationship will look like. And we wanted to know those nuances because those were where women were making the actual decisions to use tools. We also wanted to know how women thought about HIV and risk for HIV in their communities. Since we were interviewing both women living with HIV and those who were not living with HIV, for those not living with HIV, we wanted to know their engagement with current HIV prevention methods, whether that was testing or behavioral-based methods such as abstinence or serial monogamy. For HIV or for women living with HIV, we wanted to know if there were points before their diagnosis where we, and that's an intentionally broad we, that's not we as researchers, that's we as the communities to which they belonged, could have intervened to offer HIV prevention services. And then finally, and very straightforward, we wanted to know the methods, messages, and messengers that could help disseminate information about PrEP to women like them, to women in their community, or to women they thought would need PrEP. Again, a lot of questions to ask. So to do that, we did a series of one-on-one, in-depth, semi-structured interviews with self-identified Black and minority ethnic women who had been sexually active in the past 6 months. I very intentionally say self-identified BME women because this was not just cis women, it was also open to trans women. Unfortunately, because it was such a short recruiting period, I was doing this as a university student. We didn't have enough time to form the connections that would have brought more trans women into the study. The reason we chose to use in-depth interviews is that most of the women to whom we spoke were PrEP unaware. They had never heard of the drug before. So having a really one-on-one conversation, we could talk more about what has PrEP been like in the UK, what is the history of PrEP and its use in the world, what do you want to know about PrEP? And in that way, instead of just being an interrogation where we repeatedly asked people questions about their lives, we got to share a little bit more about our thoughts on PrEP and how we were approaching the research and help with any information navigation participants might want. In-depth interviews and being one-on-one also gave the advantage of confidentiality. Within these interviews, women were disclosing sex work and partner infidelity, violence, abuse, and we wanted to make sure they had a space in which they felt they could share and also a space in which we could very rapidly stop the interview and attend to them as people, not just to them as research participants, if something were to happen. Intentionally broad sample, so we ended up doing 32 interviews. And if anyone has questions afterward, I would love to speak about how you can do recruitment through a variety of means, because that was one of my favorite things about getting to do this study. So in addition to working with some really, really incredible third sector organizations who had connections in the community, in London, especially with Positive East, in Glasgow with Waverley Care, who I think made all of Scotland feel like home to me when I was there for my fieldwork. We were working online. We had HIV activists doing online ads and tweeting out to their networks. We were doing, Black Pride festivals to not capture women, but to put the study out to women who might identify as queer. We were working with other organizations who were doing service delivery outside of sexual health, so who might be doing education services for women who had recently arrived in the UK. Just to touch on a little bit more very briefly about the sample, again, 32 interviews, 22 in London, 10 in Glasgow. We tried to stratify by age and HIV status. We wanted, again, a wide range of opinions. So what were your thoughts on safer sex if you were the person who came of age during the AIDS crisis? If, your first experiences with sex were also experiences which might have involved fear because of a new disease? What were your experiences with safer sex if you had always lived in a world in which HIV was a thing? If you knew by the time you became sexually active that it was not a death sentence. Not captured in this chart, but we also very much wanted to see the difference of migration patterns to the UK. So all of the women in our study had been born outside of the UK, though many had lived for many, many years, if not decades, within the UK. Did it make a difference to how you were going to approach thinking about HIV and thinking about HIV prevention if your background involved family-based migration versus if it involved refugee experiences and asylum-seeking experience? What was the influence of being under a different healthcare system, accessing care through NHS Scotland or NHS England? We were quite pleased with the 32 interviews we had in getting such a broad range of experiences. I am a visual learner, so I'm going to throw a diagram at you. There's a lot of text on this, and I don't really expect people to read it, though I'm happy to share it later. But the way we thought about all of the data we got out of these 32 interviews is to use the social ecological model. And the social ecological model says that your personal health behaviors, so whether you choose to vaccinate your children, when you go in and see a primary care provider, when do you see your GP, and even if you consider yourself as a candidate for PrEP, are influenced by multiple levels of your social environment. So it's not enough to just say, I as an individual know about PrEP, and therefore that is what shapes my decision to get an HIV prevention pill. It's also important to say, this is how my community talks about HIV. These are the interpersonal relationships I have with my partner or with my friends, and how they might support me in sexual health care. And this is the policy of the place in which I live. This is how my healthcare system does sexual health. This is how my healthcare system thinks about Black bodies and women's bodies. All of those things matter for people making a decision to get on PrEP. So coming out of these interviews, we were able to group both the barriers we were seeing to PrEP use in women and PrEP candidacy in women, as well as the potential facilitators. I do want to caveat this all by saying that because most of the women in our studies didn't know about PrEP, we're working off of opinions about general sexual health services. So for instance, if a woman raised a concern about getting HIV tested because her friends had said to her, oh, you don't need to get HIV tested, that's not something that we do, we figured that same issue might apply to a woman discussing PrEP with her friends, because that underlying HIV stigma was likely to still be there. Now, that may be a completely incorrect assumption for some of our barriers and facilitators. Women may have gone away from these interviews, and likely did go away from these interviews, having more thoughts about PrEP and how it could fit into their lives or their communities, and they would have completely changed what they would have told us the next day. We didn't have any follow-up interviews to assess that, unfortunately, but I want to give that as the caution in how you interpret the model as well. Again, a lot of text to throw at you. So instead of just kind of sitting here blithely and looking at the model for the next couple of minutes, I want to give the 3 key lessons that I saw coming out of this research, pulling from this model. What do we want to know if we are going to set up better policy and programs for informing women about their sexual health options? So the first lesson that I take away from this is that understanding divergent definitions of safer sex is imperative to increasing PrEP candidacy notions. Safer sex is a really wonderful term that we all think we know what it means, but really we only know what it means to us. Fear of HIV acquisition in our study dictated feelings about safer sex for a generation. For most of our older participants, women who had become sexually active at the height of the AIDS crisis, safer sex meant tools to them. It meant condoms and testing. For women under the age of 25, women who were recently become sexually active or had become sexually active in the past couple of years, that's not what safer sex meant to them at all. Safer sex to them meant things like emotional, holistic health. It meant issues like consent. It meant whether or not they could access their reproductive rights, both within that partnership, within the person, the relationship with the person they were having sex, but also within the community in which they lived. And that's not to say that those issues about consent and reproductive rights and emotional holistic health weren't important to other women. They just wouldn't have always been included in their definitions about safer sex. Why does this matter for PrEP candidacy perceptions? Why does it matter for the sexual health that's being run out of a clinic? I think for PrEP, this means especially that we're going to develop a message around, here is how you can think about PrEP. And for many women, it's not going to be the message that speaks to them. So we need to be prepared to have a variety of messages, a variety of ways about talking how PrEP might fit into someone's sexual health life that are going to appeal to how everybody thinks about it. So just saying, for instance, PrEP is a tool to make sure that you don't contract HIV won't necessarily appeal to anyone who wants PrEP to be a tool that helps them navigate consent with their partner or helps them think about how their body works within society. Having all of those options, having different ways to think about the tools in our toolkits is just as important to having the tools in our sexual health toolkits at some points. Another way we can think about the differences in understanding safer sex is to think about how biomedical tools, things like PrEP, things like condoms, things like testing, can take on a social purpose too. So I was speaking with an older woman for the study. She had been married for many, many years, had been with her partner for many, many years, and she spoke about the fact that she continued to test with her partner. So she, in the midst of this conversation about PrEP, gives the discussion that if you encourage your partner to test, if you ask them to keep testing and frequently testing, it motivates that partner to be clean, to stay safe at all of the times. For her, testing was a way of motivating her partner to be faithful, and also of understanding that when they went in to get tested, it was a sign that her partner cared about her. Yes, it was an important contribution for staying negative. Yes, it mattered that, she knew about her own health status, but it also mattered to her that her partner was going to show that he cared about her. And that is a valid use of a sexual health tool as well. Making sure that you feel emotionally supported in your sexual relationship is not separate from making sure that you are STI negative. Now, that's obviously a privileged view. This woman had the ability to negotiate with her partner, but it's also something we need to be thinking about as we talk about the tools we can give to women for their sexual health, because these tools won't just have one purpose. While many women rely on those social networks for sexual health information, PrEP might complicate that pattern. So women were incredibly, incredibly enthusiastic about PrEP when they were told about it. Next slide. And that high level of enthusiasm often meant that they were willing to share information about PrEP with their friends. They wanted to talk to their friends about this new drug that they had heard about. They wanted to talk to their friends about the fact that, next slide, they wanted to talk to their friends about the fact that there was a research project going on which would allow them to talk about sexual health. But they also often caveated that with the fact that they didn't really want to go much below the surface of what PrEP was. It was completely acceptable to say, yes, I know that there is this drug out there. If you're ever interested, you can look at this pamphlet for more information. It was a very different thing to say to a friend, I'm worried about you and your relationship. I'm worried about what your partner might be doing. I'm worried about, or I want you to have more fun with what you're doing. Can we talk about this drug? Because that started to implicate judgment, that started to implicate condemnation sometimes, is what women thought, in a way that might be taken badly and might be taken as insulting by the person hearing about it. Next slide. As one participant explained, we'll go one slide beyond that too. As one participant explained, it can bring real trouble if you tell your friend to go do an HIV test, for example, and she goes back and talks about that with her boyfriend, and the boyfriend thinks that you, as the person who has given the information, is trying to stir up trouble. Next slide. Women were also concerned that if they brought up tools about HIV prevention, they might themselves be seen as being HIV positive, that might be an assumption somebody made upon receiving the information. What women really wanted was a cover when they were sharing this information. And I want to take this moment to highlight some amazing work that was done by Josina Caliste when she was at Prepster, which trained women to speak about sexual health within their own communities. Women wanted an official title or designation. They wanted to be a sexual health advocate. And when someone was asking them, well, why are you telling me this? Are you concerned about me and my partner? Are you HIV positive? They could say, no, I'm a sexual health advocate, and I've learned about this, and it's my job to share it with the community. Because that allowed them to come in a professional role. They didn't have to implicate their own sexual health personally, and they didn't have to implicate their partner's sexual health. Finally, and I know I'm running short on time, next slide, the final, I think perhaps most important takeaway from the lesson is that our current delivery pathways for PrEP might hinder access to the drug. Next slide. There was an article in The Guardian maybe a day or two ago that spoke about the fact that 2/3 of Black Africans surveyed in the UK felt that the NHS did not treat them as well as it treated white peers. And that certainly came through in the study. Women complained about issues with racism, especially in Glasgow. In London, women felt that they were being asked to use birth control because the NHS did not want them as Black women having more children. And this was all compounded by instances women felt in which people living with HIV were also discriminated against, a discrimination they also felt had roots in racism. That's incredibly concerning. And thankfully, not every participant in our study brought this up. These ended up being very few participants, but it's still very, very striking. And certainly something that is going to hinder access to sexual health care, but more importantly, hinders having a society in which Black women in general are valued. Medicalized pathways, when we ask women to come into clinics and get these drugs, always appeal to power and always appeal to who has the power to speak and who feels comfortable to speak. And in that, medicalized pathways are going to foreclose access. Next slide. Now, that being said, while I think that we as researchers and we as health activists need to work on taking PrEP outside of the clinical setting, next slide, women in the study were still very much comfortable with it being delivered through the NHS in some manners. Next slide, please. They just didn't want it delivered at sexual health clinics, which is where most of the PrEP was being delivered, if not all of the PrEP was being delivered in the summer of 2018. Women instead wanted to be able to go to their general practitioner to access this drug. For them, and as one woman explained it in two ways, everyone goes to the GP for information. That is your point of contact. That is your point of trust. You know this person. If you've never been to a sexual health clinic before, the GP is comforting to you. The second reason they wanted to go to the GP, as she goes on to state, is that there's no stigma attached. I don't have to hide or anything like that. It's good to be in there, and by there she meant sexual health clinics. But I think starting at the GP service, it's really, really needed. And that also provided women a way in which they felt that PrEP was more normalized. That if you went to your GP to get birth control and that was a part of your sexual health toolbox, why couldn't you go to the GP and also get PrEP? What made PrEP different and special that it had to be given out at a sexual health service? And for many women who were not accustomed to going into sexual health services, that was going to be the one thing, or one of the many things, that was blocking them from seeing themselves as someone who could use PrEP, because they didn't see themselves as someone who would go to a sexual health clinic, even if they could see themselves as someone who would ask that question of their GP. Next slide. I'd be amiss, even conscious of time, if I didn't give a huge thank you to everyone who helped with this research. I worked with, I think, the best research advisors on this, people who made me a better researcher, but more importantly, a better human. And that praise also applies to all of the organizations who helped me recruit women and speak with women and shape this research. And then finally, a huge depth of gratitude to the 32 women who sat down with me and for an hour, if not more, shared incredibly, incredibly personal details about their lives. And with that, I think I'll turn it back.
Thank you very much, Sarah. It's actually great to see a study that's focused on women, and also one that has, both women living with HIV and those who are not living with HIV. And I believe there'll be a lot of learning for people from this research. There was a question for you, but unfortunately, because of the time factor, we have to move on. So maybe we'll pass the question on to you and see how we can get the feedback round to everyone. So thank you so much, Sarah, for sharing. I would like to hand over to our next set of speakers who will be giving a joint presentation on the topic using stakeholder engagement and co-production to enhance research design and dissemination. How can this inform HIV research? So we have Mar Estupinan Fernandez de Mesa, who is an experienced public health specialist and policy formulator working with multiple communities both within and outside the UK. And we also have Dr. Melvina Wode Owusu, who has extensive experience both on national and global fronts, exploring migrant health and HIV in African communities. Thank you so much to both our speakers for coming, and I'll hand over to you now.
Thank you very much. Thank you for inviting us. We are just delighted to be here, to share our experience on co-production and engagement and translating research findings into practice. Our research was focused on transmitted infection, but we feel that this could inform and support the research community in the HIV field, just to plan and develop research questions that may have greater impact and relevance. So what we would like to slides are not moving forward. No, sorry. Yes. So what we would like us to cover today is we would like us to start with giving you a context for our research and what we found, and then what was our challenges to translate those findings, the approach we follow, and the benefits and limitation that we reflected on after doing our job, and then we would like us to also share with you broad reflections for the HIV and the sexual health research. So what we learn in STIs, what can we just bring into the HIV field, and we will have some final discussion points. And before we start, we would like us to highlight that we will be using terms such as engagement, involvement, and co-production. And we have heard already those terms in the previous presentations. We want to say that we recognize that those terms are used interchangeably, although they do overlap in some aspects. But we consider that they all have unique concepts. So we will be discussing this in more detail later on in the presentation. But just to start with, we would like to say that when we talk about engagement, we will be referring to dissemination of knowledge. When we will talk about involvement, we will refer to actively including stakeholders in the research process. And when we talk about co-production, we will be referring to that joint and collaborative working approach. So for the context, as like I said, our research was focused on sexually transmitted infections. And as we all know, STIs, including the HIV, are a major public health concern. Every year, nearly 500,000 STIs are diagnosed in England, and the number has been rising year on year. We know that for people of Black Caribbean ethnicity, they experience the largest burden of STIs. For example, the latest data, which is like between 2018 and 2019, the STI diagnosis rates remain highest among this group and rose by 9%. From the graph, what it shows you is the different STI outcomes among different ethnic groups. And although you won't be able to see the detail, what we want to highlight here is that you can see that the rate per 100 population is highest among Black ethnicity minorities, and is still higher among Black Caribbean populations. So having this context in mind, and in the light of the existing sexual health inequalities, what happened is like researchers from the University College London partnered with Public Health England researchers to explore what factors might explain why people of Black Caribbean heritage experience the highest rates of STI. So briefly, just to let you know about the project team or the project research. For the past 5 years, the National Institute of Health Research and the Health Protection Research Unit, which is led by UCL, as I said, in partnership with Public Health England, undertook collaborative research with two main purposes. The first one was to address the key priorities for the prevention and control of STIs and blood-borne viruses. And the second was to use those findings to inform and drive policy change and practice. As you can see from this on the slide, the HPRU unit focused on 3 research areas. And today what we are going to focus is on theme A, which was understanding risk and risk reduction of STIs and BBVs. So if we move forward, just to give you a very brief outline of the theme A. So this was the focus of the theme A was to improve the understanding and knowledge base of the behavior, attitudes, and factors that influence the risk of acquiring and transmitting STIs among people of Black Caribbean heritage. This was a mixed method research project. And the second stage of the project was focused on translating the research findings into resources to support commissioners, decision makers, third sector organizations in developing effective sexual health promotion activities and interventions to reduce the STI prevalence among people of Black Caribbean heritage. So in short, what we were trying to do was to influence policy and practice. If we move on, so just to give you an outline of the main research findings. So there was 3 key areas, and this was around access, the drivers that may influence the STIs, and the needs the population have. So in terms of access, what we found was that Black Caribbean community members are more likely to access sexual health clinic than those of white and white British ethnicity, which is good. The drivers that may influence STIs. So what we found is that there are 3 key factors that statistically increases the chances of being diagnosed with an STIs, and these are having first sex experience at a younger age, having a greater number of partners overall, and having more than one sexual partner in the same period of time. And in terms of need, is what we found is there is a need to raise awareness and support communities to make informed decisions to improve their sexual health and well-being. So from these research findings, 3 priority areas were considered as the most important to help reduce the high rates of STIs among people of Black Caribbean heritage. I mean, there's a lot of information there, but there was three key areas, and these were empower women and improve their negotiation skills, although it was acknowledged that this is an important factor for everyone. Encourage people to engage in respectful sex, and just raise awareness and improve knowledge on STI and STI risk. So, like we said, our main focus was about translating these research findings into practice. So, when we were reflecting on what the best approach to translate those findings was, we faced a number of challenges, and then we are highlighting here the 3 main ones. And the first one is that we were dealing with a taboo, a stigma, a sensitive research topic, and a target group where the research findings could have led to an exacerbation of already existing marginalization and stigma among these communities. We were also dealing with a complex public health issue this requires a whole system approach. And what we mean is that we needed to interact with a wide range of stakeholders. And in terms of the research findings themselves, we were thinking about how we do present these research findings, how we do translate those research findings, because what we wanted was just to influence behavioral change. So how we could emphasize the relevance and the importance and usefulness for the members of the public. Then we wanted just to influence decision makers and commissioners just to change practice and just to drive policy. So they're thinking about how to ensure just to make those findings visible and accessible to them, because they have these competing priorities and they are operating in a field where there is bias is a challenge. There's other issues, other challenges that we need to consider was yes, we have the research findings, but how can we translate those findings something which is actually actionable? What are those recommendations that then decision makers and policy makers and commissioners can action? Then there was something around to ensure the findings can influence implementation and service delivery. And finally, we were thinking about, we have the research finding and how can we influence that those in research and then the policymakers actually bring the community in the thinking to develop interventions and develop different activities just to influence behavior change. So taking into account all of these challenges, we agree that to translate, for the translation exercise, we needed to have a very well-designed and robust framework and strategy to minimize the potential negative impact on communities while ensuring the research findings had a wide impact on influencing policy change and practice. We also recognize that we had to consider two key groups, and I had been talking about the policymakers and the community member, and this was because we need to think about those who affect the change in policy and those who are affected by poor health outcomes. So what we did is we use an evidence-based framework based on 5 questions. And this enable us to reflect further on how to shape our translation. So we started with this, with the what should be transferred. And this is about the message. So for us was about what are the actionable messages that can be translated in recommendations. Then to whom should research knowledge be transferred? And this is about thinking on the target audience. For us, for example, was about our target audience was the community members, the policy and decision makers, the commissioners, the clinicians, the practitioners, the third sector organization, and also the academics. By whom should research and knowledge be transferred? So you need to think about who has the expertise to do that translation. In our case, we convene a multidisciplinary translation team, with epidemiologists, researchers, and policy experts. Then we thought about how should research knowledge be transferred. So this is about the process. For us, and we will be talking about this later on, was about engagement workshops, co-production, and dissemination. And finally, with what effect should research knowledge be transferred? So what is what we want to achieve with that translation? For us, was about driving policy and practice change. It was about influencing behavioral change, and it was about influencing new research. So moving on, before we just explain you in more detail how we just deliver our workshops and the whole process of translation, we want just to go back to the terminology. We were talking at the beginning of the presentation that we think that terminology is very important. When we talk about terminology, there's these four terms, which is about stakeholders. We need to think about who are our stakeholders in the research process, from the researchers, from the members of the public, commissioners, and so on. When we talk about engagement, we are thinking that this is about the dissemination of knowledge, but there is also an opportunity to from those who participate in the workshop, in the engagement workshops. When we talk about involvement, we are talking about actively involving a stakeholder, and this is thinking about that we ensure that research is carried out with or by the members of the public, rather than just to or for them. And finally, co-production is just to ensure that stakeholders participate and co-produce and co-create the research question, any other products that you want to produce at the end of your research process. what I think is important that we want just to highlight really here is that in our view, like we said before, is that using the right terminology when you are just designing your protocols is important for clarity. So to ensure that all stakeholders, including the researchers, the research participants, the funders, and the decision makers, they all understand their roles and what is expected from them in any research program. But we really think that involving members of the public and key stakeholders in the research process is important that this happens at the very start. So this help ensure research quality and relevance, and it also enables end users to inform and develop research questions, set priorities, and co-produce resources that will benefit them. In our case, however, the engagement, involvement, and co-production happen in the translation stage, so a bit later than we would like to see in future research. But still, this was a great opportunity to share knowledge and receive feedback, and it was an opportunity to bring on board key stakeholders to co-produce the final products. So I'm just handing over now to Melvina.
I'm really conscious that we're running into breakout group time, so I'm going to basically take you on a whistle-stop tour and speak as quickly as I can, but hopefully you'll understand what I'm saying. So Mars helpfully explained the translation framework that we used, and I hope just to explain our approach in a little bit more detail and also pave the way for our discussions about extending the involvement of stakeholders in HIV research, and particularly throughout the research cycle, which Bakita, Hosanna, and Sarah have also touched on as well. So very briefly, Mars already mentioned that we conducted some workshops in which we sought to engage, involve, and co-produce with our stakeholders. So we did 2 separate workshops, one in November last year with community members and their representatives, and their second one in January this year. And the purpose of doing them separately was to create safe spaces for reflection for different types of groups, to prevent the community groups being overwhelmed with public health and sexual health jargon. But also we were deliberate in sequencing these workshops because we really wanted the decision makers meeting to really take account of the findings and outcomes of the first workshop. Next slide, please. So there were obvious key benefits, and I think the main one was just having that robust framework that Ma mentioned. This is such a huge area, and involving stakeholders at a time when they're not usually involved generates a lot of discussion. And by having that framework, we were able to go back and really think about what our message was, who needs to hear it, how they need to hear it, how we want to convey it, and the effect that we want to achieve. Next slide, please. I think one benefit that I'd like to draw attention to is actually that I think that workshops, although we plan to engage and disseminate our findings and discuss them, I think they also served a health promotion purpose, particularly for the lay attendees and the more generalist public health policymakers that attended, because in many respects you find that sexual health is decided upon by people that are not necessarily specialists. They might have a wide portfolio of public health issues to manage. And what was quite interesting is that many of those generalist policymakers said, I didn't know that. That's really interesting. And so in that sense, it served as a health promotion tool for them and an awareness raising tool for them, as well as the lay members. Can I have the next slide, please? So with all exercises, particularly co-production, because we're still really learning how to do this, we experienced challenges. And you can see a couple of points on the slide, but I just want to pick up on 2. And one was that this process demanded a lot from our stakeholders. We were really trying to avoid being London-centric, and we wanted to have representation from Leicester, Leeds, Manchester, and places where we know there are high STI rates among Black Caribbean communities. But in doing that, it did mean that they would have to travel to London to take part in this. I mean, obviously the world is changing now and that we're doing more things remotely and online, but this did mean giving up a good half a day to a full day's work for some charity representatives. And as Hosanna was saying, a lot of these are already struggling to either receive funding or make that funding stretch. And so it's a really big ask for them to give up their time to contribute in this meaningful way. So it definitely wasn't tokenistic. The second point was that this process is very labor intensive for the team, and it's definitely worth pursuing, but I think it's something we need to write into our proposals and our bids at an early stage to make sure that we can fund them appropriately and have time. Next slide, please. Actually, we'll go to the next slide even. So I just want to highlight the research cycle, and I think a couple of our speakers have touched on this before. While we think it's really important to involve our stakeholders, and I mean the whole research community, in the topic setting and prioritization stage of research, we really have to consider that research is a cycle. And once you've involved those stakeholders, perhaps in the development or the early stages, we need to think about how long we need to engage the stakeholders for and in what capacity. So we've heard from Bakita as a peer researcher that she has so much knowledge and so much expertise now, but what we might think about is whether we need to supplement that expertise with people who might be living with a specific condition but do not have the same level of insight into research and perhaps might ask different questions as well. So I think it's really important to consider that people living with HIV or any group really can input in research at all of these stages, and it doesn't have to just be at the beginning or just at the end. Next slide, please. So I really want to just kind of take a bigger picture view before moving on to our breakout groups. And whilst I've described that research translation doesn't just take place in a bubble, I think the whole idea of research doesn't happen in a vacuum either. So we don't have people who are sitting waiting to be invited to take part in research. And so it's really important for us to consider the context. I know we've tried to avoid saying the C word here today, but it is really important to think about 2020 and after 2020 and what HIV research looks like now. I don't think it's all bleak. I think there's many opportunities. In particular, the various concepts now that have just gained a new meaning and importance in society. So people understand what research is now, public health, contact tracing, even knowing what a virus looks like. All of these things are now part of our public discourse. They have a public persona. And it's really important for us to think about how we can capitalize on this listening ear, if you like. In particular, like we're doing today, we're talking about ethnicity and race and health inequalities. And I think while we have open ears, this perhaps is the time to talk as communities. But equally, I think having this pause time gives us an opportunity to really reflect and to listen to one another and work as a community of researchers, whether lay researchers, peer researchers, academic or clinical. We can work together in a more co-production, co-creation type of system. So along these lines, I think what we would advocate for is more of a whole systems approach to research. And we think that this can really benefit the development of research questions, as well as the translation of research into products, policies, and practice that benefit BAME communities. Could I have the next slide, please? So considering the importance of working with stakeholders at different stages of the research cycle, what we propose really here is that we ask some high-level questions, and it's quite a long question and specific. So are the key stakeholders in HIV prevention, treatment, care and well-being, are they engaged, involved and co-producing enough in research? So we know that it is happening, but is it happening enough? And is it happening at the most impactful stages? We need to really ask ourselves who's leading the research and why are people being involved? I think I really would love us to move away from the tokenistic PPI representative and really think about some of these questions that we've posed here. And these, again, may not be the right questions. And I think it's very much for the whole research community to reflect on. So I won't read them all out, and I'm sure that the slides will be shared, but I'll just pull up one, which relates to, I think, a running theme through everyone else's presentations, which was about stigma. And that's question 5 on the slide. So if we ask, who are the key stakeholders affected by and affecting HIV stigma? And we need to think about whether or not those people are involved. So I know we've got a really exciting program to carry on with, so I don't want to take up any more time, but I would just like to say thank you to everyone who has contributed to the HPRU study, in particular the 27 people that gave up many hours of their time to support us in translating these research findings. Thanks very much.
Oh, thank you so much, Mara and Melvina, for your really stimulating presentation. I'm really sorry we haven't got much time for questions, but I think the takeaway for me would be, in summary, you had a lot of great stuff in there, but I think the summary would be just ensuring that we have respectful partnerships and meaningful involvement that is also safe for people. So thank you so much for that. At this stage, we are going to move on to the next part of the webinar, which is going to be on Zoom. So I think if everyone can look through their emails, there was a Zoom link that you got yesterday. You've been allocated to one of 3 rooms. You will have a host there who will moderate your discussions. And after the breakout sessions, we will come back to the same link again for feedback. So if we look through our emails and click on the link, it will take us to Zoom. And then if we're back here for 3:45, please. Yes. Welcome back, everyone. I hope that you were able to have vibrant discussions in your sessions. Unfortunately, we ran out of time, so we apologize for that. But we also got some rich content. So I'm just sharing from my session what we had, and for us, we said that the research priorities that are relevant for women is that it's really important that researchers approach the community, and that is by building trust to be able to then address and understand what is important to community rather than imposing research questions. And that policymakers and the community need to align in order to be able to successfully implement programs, but also have programs that are suitable for community. And then we also said about making sure that research is community-led. We said that researchers would need to have open and honest and transparent intentions, and have meaningful community involvement, because that's the only way that that's going to happen. And also we said about, sometimes people get the idea that communities are hard to reach, and people shared about how some community members are really active, but that also means that it needs a lot of investment in the community to then be able to get them to be that active. So we also said about private and public funding. How do we make that happen? There was a challenge of long-term investment, that women need long-term investment, because otherwise then the funding is short, and so the benefits of the gains that are made are lost because there's no sustainability. But I think from our group, the most important bit was that trust has to be built by stakeholders, and to make sure that we move forward. So thank you to all the people who contributed.
Thank you, Longret. Like you, we had very rich discussions in our group too. And I think we built up from Bakita's question on engagement in research and peer researchers and what the roles are, and the importance of having people lived experience that also have different technical expertise, and then important to involve a variety of individuals. And I think another big thing that we discussed was the barrier to migrants accessing HIV care in the UK, getting those individuals involved in research, how to manage payment to participants that do not then interface with their benefits or universal credit and or other things that they may be receiving. So we need also to while vouchers work, I think we raised a point that we need to discuss with our participants which voucher they need. Um, let's not assume that we know what a participant needs, or just have a generic idea. And I think, and then there was the barrier for women accessing PrEP. Um, it is important for PrEP access, even if a woman has one exclusive partner, but they may have numerous partners. So we need to be really open to give women that empowerment, that voice to challenge why PrEP will be good for them. And then again, I think we need to be able to access people who are not engaged in the groups. We need to work and recruit individuals, more individuals. We need to stop recruiting the same people, asking the same questions. There was a point that there's data or there's questions that were asked 10 years ago, 5 years ago, 3 years ago, and we all now know each other, especially as participants within the HIV sector. And again, it is important to communicate results and outputs of every research back to the participants so that they feel that they actually contributed and it wasn't something that was micromanaged just for that part. And I think I'll conclude with one very essential point about researchers being able, again, it's about being able to involve the participants right from the beginning and giving us the opportunity to be able to do what we do best. And there was a good discussion with a researcher on here about the wins where we are now, but also an acknowledgement that there is a way to go, and an open invitation to participants to say, please challenge us for us to get it right. I shall leave it there because of time, but we will share these feedbacks. Rageshri?
Thank you, Fungi and Longret. So we were the third group, and we really talked about what we thought were useful research questions at the moment. So I'll just list some of them. So we started talking about breastfeeding, and we heard about a project that is going to be starting in February, which is really going to be investigating how women living with HIV make decisions about infant feeding. So, what are the factors in their mind when they are making decisions, and really what kind of resources can we make to help support them? So there's a lot of discussion about that, and that also kind of led on to why don't we know really for sure whether U equals U applies to breastfeeding? Is there any potential to collaborate in a very large study looking at U equals U and breastfeeding, so that people feel there is more evidence to support that breastfeeding is safe? People may want more evidence for that. We talked about there being a gap in research data on the experiences of antenatal and postnatal care for ethnic minority pregnant women living with HIV. We also talked about we should really be looking at the experiences of women who live outside of London. So, for example, I said that I work in a big teaching hospital in London. We have a specialist HIV midwife, whereas another member of our group worked outside of London in a smaller hospital. And although they had a very good service, they didn't have a dedicated midwife for HIV. So really trying to find out from those women who are experiencing pregnancy outside of London and outside of the bigger centres what their experience is like would be very helpful. And then moving away from pregnancy and breastfeeding, we talked a bit about mental health and well-being. So, for example, if someone was to see, say someone wants to see a psychologist or peer support worker, would they feel more comfortable talking to someone from a similar ethnic background to them? So whether that's actually being looked at and if there's any evidence around that. We talked about aging for women living with HIV from ethnic minority backgrounds, and again repeating what Bakita said about looking at the differences for people who may have been born with HIV and thinking about not just age, but also how long people have lived with HIV and how long they've been on antiretroviral therapy. So those were the priorities that our group thought was useful, and we didn't get onto the PrEP question, unfortunately.
Well, I think we all three groups covered a vast amount, covered a lot in a very short space of time. It is now my pleasure to conclude our webinar, and I want to thank everyone for participating. Thank you for being with us these couple of hours. Thank you to Beaver for sponsoring this podcast, and would like to remind everyone that the recording is available on the Swift website along with part 1. And we will be writing a report with a summary of the 2 symposia, which we'll share. This report will aim to develop recommendations. And I want to say thank you to all our wonderful speakers, and last but not least, the technical support team that you may not have seen, but they have worked so hard to bring this together for us in a very short space of time. Thank you, everyone. From Swift, I wish you all a wonderful weekend. Be safe. Goodbye.